Good afternoon, everyone. On behalf of the Culinary MD team, we'd like to appreciate you all for joining our webinar today. We are actually excited to have over 600 registrants, but of course, our portal is also limited, and so this webinar is recorded and will be posted in our website so that you guys can revisit the material and go back to the topic, maybe share it to someone you know who has been struggling with chronic acid reflux. So this will be the first topic of our September webinar series. As you can see, on the second session, we'll have fatty liver disease reversal, and it will be followed by prediabetes and diabetes type 2 remission. So these two conditions usually go together, and so we hope to have you again in those sessions. And maybe you can invite your friends to join us too. Our participants for this webinar is a mixture of physicians who are into the practice of lifestyle medicine. We also have allied health professionals, health coaches, patients, and maybe others just want to learn about how culinary medicine can help a specific chronic condition. Some of our participants here are students in culinary medicine. Others are taking up the basic course, which is open to anyone who wanted to learn about how food interplay with lifestyle and risk factors for chronic diseases, and how can this knowledge be translated into food preparation through healthy cooking in their own kitchen. Others may be taking the professional course in culinary medicine, which is leading to a certification to become a culinary medicine specialist. So the culinary medicine specialists are part of the collaborative team who provide lifestyle-related coaching programs to patients who are suffering from chronic conditions such as acid reflux, fatty liver disease, diabetes, heart disease, cancer, hypertension, obesity, so on and so forth. So for those of you who just learned about us, you may visit our website. It's culinarymd.org and take advantage of the free resources that our team provides. Our goal is to encourage individuals to provide home cooking, as it is proven to decrease risk for chronic diseases that we mentioned earlier. And since Culinary MD is celebrating its 7th year anniversary, the team is giving out limited slots of 80% scholarship for culinary medicine course. And you will get a free hardcover copy of the Culinary Medicine Handbook when you register for the professional course. So visit our website and our Facebook page for details, or maybe you can send direct message to our team through email or Facebook Messenger. This is also a part of the community-based lifestyle medicine advocacy of the Philippine College of Lifestyle Medicine, or PCLM. The PCLM is an affiliate specialty society of the Philippine Medical Association under the division of the Philippine Academy of Family Physicians that provides training for physicians who utilize lifestyle intervention for the prevention, treatment, and reversal of some chronic conditions. All right, so this webinar will provide an overview of the evidence-based lifestyle and diet modifications that can be helpful to manage patients with gastroesophageal reflux, or GERD. Okay, so this is one of the most common disorders of the gastrointestinal tract, and actually in the 2021 clinical guideline for the diagnosis and management of GERD, the American College of Gastroenterology defines GERD as the condition in which the reflux of gastric contents into the esophagus results in symptoms and or complications. So if you would notice, the two most common symptoms, that are being complained by these patients with acid reflux are heartburn, which is a burning sensation from the upper abdomen going up toward the neck. And there could be a presence of regurgitation, which is the effortless return or backflow of the gastric contents going up toward the mouth. However, GERD was also noted with association of other symptoms like chest pain, hoarseness, chronic cough, and frequent throat clearing. And of course, we know that the most feared complication is cancer. So to make this simple, GERD or acid reflux occurs when there is a dysfunction at the esophageal sphincter. So you can see it there. So this is where the stomach and the esophagus meet, and some of the contents that are supposed to proceed down to the small intestine would end up going upwards, which is the wrong way. So there's no one identified specific cause of this dysfunction that may account for all individuals suffering from acid reflux. But beyond the uncomfortable symptoms, GERD is also problematic because of the chronic exposure of the esophagus to the gastric acids, which can lead to tissue damage. So this complication usually begins as esophagitis or inflammation of the tissue, and over time it can lead to Barrett's esophagus. So this is the condition by which it has a distinct change to its cell lining. So this is so much concerning because Barrett's esophagus significantly increases the risk of developing esophageal cancer. So the early management of GERD is critical, not only to avoid the short-term consequences, but also to minimize the risk of long-term complications. That includes, but not limited to, esophageal cancer. So the way we manage GERD usually calls for a comprehensive approach that would typically require pharmacologic measures, especially the use of proton pump inhibitors, such as omeprazole, pantoprazole, and esomeprazole. And we also have non-pharmacologic measures that are equally important as initial and maintenance intervention, including dietary and lifestyle modifications. And in severe cases, surgical intervention may be necessary. So for this webinar, we will be focusing entirely on the non-pharmacologic measures, which is divided into 4 subcategories. So under lifestyle modification, we have weight management, meal timing, tobacco and smoking cessation, and the identification of trigger foods and beverages. Now we'll jump straight to the first item, which is weight management. And we know that research over the past 25 years has consistently produced converging lines of evidence showing a correlation between the body mass index and the symptoms of gastroesophageal reflux disease or acid reflux. And of course, the risk of complications from this acid reflux. So this 2005 meta-analysis of 8 cross-sectional studies showed that individuals who were classified as overweight or obese were about 2 times more likely to complain of acid reflux symptoms when compared to those who were classified as normal weight. Now, the same study also found a similar relationship between BMI and erosive type of esophagitis and esophageal cancer. This was followed by a 2006 study in the New England Journal of Medicine that looked at data from over 10,000 females in the Nurses' Health Study. And it supported the idea of a dose-dependent relationship between BMI and GERD symptoms. So this simply means the higher the BMI, the more likely a person was to report symptoms like heartburn and regurgitation. So this study also showed that significant weight gain led to increased GERD symptoms, and women with an increased BMI of more than 3.5 increased the risk of having frequent symptoms of GERD or gastroesophageal reflux disease. And on the other hand, there was a reduction of nearly 40% in the risk of frequent symptoms among women with decreased BMI. So we can see here that the effective weight loss has exported a handful of studies and have significantly shown that weight loss can lead to improvements of GERD symptoms. Although this improvement may not be completely attributable to weight loss alone, but it certainly appears that it plays a significant role. Now, with these findings, along with others, obesity is considered as a major risk factor for GERD by the American College of Gastroenterology in 2020 review published in the Journal of American Medical Association. Now, we also know that the role of obesity in the development of GERD is complex and multifactorial. But the most simple explanations include the increased intra-abdominal pressure from excess abdominal adiposity and a higher prevalence of hiatal hernia among obese individuals. As you can see in this figure, the esophagus and the stomach are separated by the lower esophageal sphincter, right? The diaphragm also works together with the sphincter to maintain the pressure gradient that is needed to keep the sphincter tight, which of course minimizes the unwanted upward backflow of gastric contents. But with the increasing intra-abdominal pressure from the adipose tissue or excess body fats, the normal pressure gradient can be compromised, which can result in relaxation of the sphincter. Now, this same pressure from the adipose tissue can contribute to the development of hiatal hernia, as you can see in this figure. In fact, a portion of the stomach slips about the diaphragm that impairs the integrity of the lower esophageal sphincter. Again, studies show that hiatal hernias are more common in people with obesity. So now, how do we go about managing overweight or obese individuals with GERD? It doesn't mean that we just generally recommend weight loss based on body weight or BMI alone. It also doesn't mean that the intervention is just to resolve the number around the weighing scale. And it also doesn't mean that we just have to recommend the usual and the common and the trending crash diets or quick fixes just to resolve the excess weight with no long-term plans set on the table. So what we mean here in culinary medicine is that we should explore the current eating pattern, the activity level, and behaviors of patients with a high amount of abdominal obesity to see if practical and sustainable suggestions can be made to induce gradual weight reduction. So this is where counseling, coaching, and motivation strategies in culinary medicine would come in. We usually meet the patients from where they are, what's doable for them that they think they can sustain. Because if we approach the case only looking for trigger foods to eliminate, then maybe we may be able to provide temporary relief, but we would likely be overlooking the root cause of the problem. Now, the next dietary factor we're going to explore is the meal timing. What we see in the current recommendations is to avoid meals within 2 to 3 hours of bedtime. Eating close to bedtime has long been associated with GERD symptoms because we understand that in theory, when you're lying flat with food in the stomach, it increases the likelihood of to regurgitate, the contents up to the esophagus. This study found that a dinner to bedtime of less than 3 hours was significantly associated with GERD when compared to patients who had their dinner of 4 hours or more prior to bedtime. So they concluded that the study showed a significant association between GERD and shorter dinner and bedtime intervals. Now, this randomized and blinded crossover trial, they actually found that patients experience significantly more symptomatic and asymptomatic reflux, because there are reflux that are symptomatic, but there are also reflux that you do not know that there are acid reflux going on because you're not feeling any symptoms at all. So here patients who had symptomatic and asymptomatic reflux after meal 2 hours before bed. And this appears to be the best evidence to support the current recommendation, at the very least, focusing on small meals and snacks in the hours leading up to bedtime should be encouraged. The third and final dietary factor that we will discuss is the identification of trigger foods and beverages. Of course, we also mentioned earlier that smoking and tobacco cessation is really necessary for patients with GERD, but as I have mentioned, we'll be focusing on the nutritional aspect of GERD management. So here you will see that GERD symptoms And we know this, that they have long been linked to specific food and beverage selections. So coffee, carbonated beverages, citrus fruits like oranges, lemon, processed and cooked tomatoes, high-fat foods, spicy foods, chocolates, peppermint, and alcohol, they have long been implicated in the exacerbation of gastroesophageal reflux disease, of course, and the trigger of symptoms. So this is because they're known to irritate the lining of the esophagus. They also reduce the pressure of the lower esophageal sphincter. They also increase the gastric acid production, and they lower the pH of the gastric contents. But as clinicians, it is absolutely important, yes, to be able to identify the known triggers from foods and beverages. But rather than providing the general recommendation just to eliminate all possibilities from the diet, it's more prudent and sustainable to let patients identify the specific food or beverage that trigger their symptoms. Now, ideally, this is accomplished through food journaling with the patient, and document what they have eaten during, and then draw a connection to how it makes them feel. So this is where culinary medicine coaches are supposed to be good at, in assessing food intake and documenting potential triggers. So please take note that it is certainly possible that we will be able to achieve symptom relief while keeping some of their favorite items, even if they have been identified as common triggers by theory. But it's also possible that there are foods that are not known triggers that for whatever reason just don't work well and becomes trigger for other patients. So patients are very heterogeneous, So what may work for others may not work for some. So we should always keep in mind that we have to let the patients participate in identifying these specific triggers. And we should also keep in mind that the more items we take away from a person at once, the less likely it is that they'll be able to identify the specific trigger. And the more items we take away from a person at once, the more likely that we make the patient feel restricted, which is not ideal for a long-term adherence to a successful dietary change. So for short, identifying trigger foods is a necessary component of nutrition therapy for GERD, but it should be done alongside fostering an overall healthful eating pattern that include food groups that include foods, that are supposed to be coming from all food groups. So here in the study, you can also see that frequency of consumption of meat, fried food, and certain types of fruit like citrus was higher among subjects with gastroesophageal reflux disease. This study also showed consistent evidence to show the role of dietary fat in causing increased frequency of transient lower esophageal sphincter relaxation and increased acid exposure with high fat consumption. Now, in this another study, on the other hand, they found that the risk of reflux among people who ate salted food 3 times per week or even more showed significant increase of reflux symptom. This is supported by another study conducted in Japan, showing that table salt increases the risk. It was reported to have significant risk factor for gastroesophageal reflux. Okay, so now moving forward, let's also put attention to the effect of specific type of dietary pattern. So in this study, it's suggesting that consumption of whole food plant-based diet, which has low fat components and high amounts of fiber, phytochemicals, and antioxidants, significantly decreases the risk of GERD. So now it's clear that we don't only focus on the triggers, but we should also discuss about what should be consumed to decrease the risk of GERD symptoms. And lastly, I want to emphasize that the risk of GERD is multifactorial, and it could also be triggered by other conditions like diabetes mellitus, which is usually one of the complications where dysfunction of the lower esophageal sphincter is found, leading to abnormal reflux. So anyway, we'll be talking about diabetes in our next webinars, and we hope we'll have you again on those schedules. So in quick summary, from a nutritional and lifestyle perspective, in the management of gastroesophageal reflux, first, if a patient has obesity, especially when the fat is deposited in the abdominal area, the most effective approach for managing symptoms appear to be weight reduction. Okay, so this is a program we want to give patients with a long-term goal of sustaining a healthier dietary pattern and active lifestyle. So second, patients should be encouraged to avoid meals, especially heavy and fatty meals, within 2 to 3 hours of bedtime. And of course, tobacco and smoking cessation is also necessary for patients with GERD. And lastly, patients should be encouraged to participate in the identification of trigger foods and beverages, which can be followed by the elimination of those that are found to be specifically problematic. So finally, it is really important to find the correctable risk factors and correct them. And all of this has to begin with the promotion of an overall healthful eating pattern that includes foods that are mostly plant-based origin, with minimal or decreased intake of fatty meals coming from animal-based sources. So the center of the plate should always be occupied with colorful variety of whole plant-based sources. So our next session is actually about fatty liver disease. Like I have mentioned earlier, fatty liver disease and diabetes, they always come together. So in September 18, that will be the next topic, and then it should be the same time of Sunday. So you will find more about gastroesophageal reflux disease, fatty liver disease, and diabetes in this handbook. This is culinary medicine. Of course, what's inside is a combination of nutrition and cooking. These are strategies used to restore and maintain health. Of course, everything is evidence-based here, based on the studies that were published that would be helpful for specific conditions. So again, you may visit our website, culinarymd.org. In case you didn't visit it yet, you may take advantage of our free resources. We have free courses there. Our recorded webinars are also there. You can just visit these free resources. We also have free recipes you can access there and try it out at home. Again, we are celebrating our 7th year anniversary, and if you're interested to take advantage of the limited 80% scholarship grant for the culinary medicine courses, just visit our website or send message through our Facebook page, and our team will be glad to help you and assist you. So thank you so much, everyone. And to those of you who are near Iloilo City or from Iloilo City, you may want to join our teaching kitchen and book reading session. We actually have 2 sessions. This will be September 18 and September 25. So that's 9 a.m. to 1 p.m. So what you will get is, of course, a shared medical appointment, both for diabetes and fatty liver disease. So if you have, if you know someone, or if you're a patient who has fatty liver and diabetes, then this session can be really good for you. We will have culinary medicine cooking session, and we'll also have book reading and book signing. And of course, we will end the session with a healthy lunch buffet. So you can always contact us using the number flashed in the screen, or you can always send us a message through our Facebook page. Again, thank you so much for joining us this afternoon. The team is so glad to have you, and we hope to have you again in our succeeding sessions. Good afternoon. If you have some questions, you may type it in our chat box, and we'll try to answer them. If not through this live conversation, Maybe we can do this through email because we have copy of your emails when you're registered, or we can send this through message. Again, thank you so much and good afternoon.